So welcome to this series called The Perioperative Coach. In this series we have top tips on all aspects of perioperative care from some of the world's experts working together to enhance surgical recovery. Don't forget to look on the show notes on topmedtalk.com for additional links to papers, etc. And of course, if you haven't done it already, subscribe to Top Med Talk. Top Med Talk 1.
Here, Dr Joff Lacey speaks with his guest, Dr Randall Dull of the University of Illinois.
I'm Joff Lacey and I'm still without Monty-Mython, but I'm delighted to have Dr Randall Dull, anesthesiologist from University of Illinois, Chicago, with me. And Randall has an extensive research interest, which include, amongst others, the physiological impacts of fluid therapy. So, Randall, thanks very much for joining us.
Good afternoon, Jeff.
How are you today?
I'm fine, Jeff. Thanks for having me.
I just wanted to pick your brains on, we had a very interesting discussions yesterday about goal-directed fluid therapy, and principally highlighting the fact that although the concept of goal-directed fluid therapy is accepted by many, and there's strong signal from the literature that it has benefit to patient outcome, there's not quite the degree of uptake that you would expect, and that's probably related to a lack of consensus amongst exactly how we do it, what goals we set, and how we use the tools at our disposal, namely fluids and inotropes. And it seems that most regimes will have a premise of using fluid responsiveness to fill until no response, and then start some kind of vasoactive inotropic therapy. Now, in your opinion, does that make physiological sense?
For the most part, that does make physiological sense, with the premise that patients actually lost fluid. And many of the talks that I give around the country on fluid-responsive physiology all starts with the very simple concept, has the patient lost volume? In my experience and in my own practice, we typically see fluid-responsive physiology more commonly in the absence of volume loss. And what that tells us is anesthetics and the drugs we're giving patients during surgery are causing vasodilation and a redistribution of blood volume in the venous circulation. And so in my practice, if they haven't lost volume, I go to inotropes first, because that's going to prevent me from giving too much fluid, and I'm going to draw on the capacitance volume that the patient has, mobilizing that venous capacitance volume back into the central circulation.
So in a lot of the circumstances that we use it intraoperatively, saying that the major colorectal patient that's been pre-optimized and well set up, euvolemic, euhydrated on arrival in the OR, the fluid responsiveness is actually a normal physiological response due to the impact of the anesthetic agents.
Sure, I think if you look at the very outset of an anesthetic case, we induce general anesthesia, which renders a patient unconscious. And as part of that physiological response, we blunt the sympathetic nervous system. That causes a shift in fluid volumes within the vascular system. We increase the venous capacitance. And simultaneously, we institute positive pressure ventilation. And all of these things conspire to prevent venous return or reduce venous return. And so we would see fluid-responsive physiology immediately after the induction of anesthesia, and yet we know that patient hasn't lost any volume out of the body. So if they're euvolemic when they came into the operating theater, to me it makes physiological sense to draw upon our pharmacological agents to reestablish that normal stress to unstressed volume ratio.
So we should have a lower threshold, really, in those circumstances to move to the inotropes and the vasoactive substances.
In my opinion, that's correct, and I think we still rely too heavily on going to fluid first rather than inotropes.
And you know, fluid is not benign, you know, and I think we've maybe got into a trap sometimes of feeling like it is a benign drug to some degree, but there's lots of, you know, deleterious impact from often quite aggressive fluid therapy.
Yep, and I think historically anesthesiologists have viewed drugs as their fluid as their mainline drug. Patients came into the operating theater 12, 14 hours of NPO. They had bowel preps that were of the hyperosmotic type, so they really did lose a significant amount of volume during bowel preps. But all that's changed. Patients are allowed to drink, and we actually give our patients Gatorade as part of their preoperative packet. It was a process that we worked out and I was involved in. We have a deal with Gatorade that we get Gatorade packets that we give to our patients. They come in euvolemic. They're all getting isoosmotic bowel preps. So they're really euvolemic when they come into the operating theater. There's no need to make up this 1 or 2 liter volume deficit that I think many anesthesiologists believe our patients are starting at.
And you mentioned this earlier, that the stressed and unstressed volumes. Can you expand on that?
Sure. I think it's really probably one of the most important concepts in vascular physiology that all anesthesiologists should understand. 2/3 of our blood volume is in the venous side of the system. And about only 1/3 to 1/4 of that blood volume actually contributes to the pressure in the venous side to drive fluid from the periphery back to the right heart, where it contributes to cardiac output. That reservoir is affected by anesthetics. It vasodilates, and so the capacitance volume increases. The stress ratio is what pushes blood back to the heart, and as a patient becomes dilated, the stress to unstressed ratio changes in favor of basically enlarging this venous reservoir. But it's richly endowed with alpha receptors, and so we can give vasopressors like norepinephrine or epinephrine to vasoconstrict that compartment, reestablish a normal ratio between the stressed and unstressed volume to essentially propel blood, cause an autotransfusion back to the right heart to improve cardiac output. Because the whole goal of all fluid resuscitation is end organ perfusion. We want to get cardiac output and flow high to our end organs to prevent damage.
Do you think on that point then, a lot of the time we're looking at the wrong part of vascular physiology, that we should be looking at the microcirculatory aspect? Most of the time we're looking at the central blood flow. What are your thoughts on that?
And I think that's a factor of just simple medical education, where overwhelmingly, as coronary artery disease is such a major factor in patient health care, that we focus very much on cardiac physiology and the arterial side of the system in medical school. And I think most people probably go through the American medical system and hear nothing about venous physiology and very, very little about microcirculatory physiology. And so that's been part of my goal in the residency education, to bring my residents and fellows up to speed on how we understand the vascular system is working.
And I suppose also, if we want to look at microcirculatory flow, we also need to have a way of measuring that, and that's part of its technology, its ability to see impacts of intervention.
Yeah, that's a great point. Technology has not quite kept up with what we understand the physiology, and so our markers of pressure and flow are still several steps upstream from being able to measure microcirculatory flow. And at our current level of technology, we really don't have good clinical tools to do that yet.
You mentioned in your clinical practice you reach for the inotrope, the vasopressor, sooner rather than later in terms of optimizing your patients interruptively. Do you think maybe the fact that that's not been done in a lot of the trials using goal-directed therapy, that the outcomes have been a bit less clear as to whether the benefits are clear-cut or not?
Yeah, I think if you look at many of the fluid trials over the years, there tends not to be very much difference in overall fluid volumes given between control groups and experimental groups, and they get muddied by substituting colloids instead of crystalloids. So it's very hard to tease out some of the physiological effects that they're seeing. But for sure, another part of historical training is that I think if someone has to use an inotrope, surgeons get very nervous. They think something's wrong. They do worry about microcirculatory blood flow. If they're doing bowel surgery, flap surgery, are these inotropes going to be deleterious to the tissue? But in the end of the day, we have to convince them that improved perfusion is really going to help that tissue.
And so in your opinion, we were talking about this yesterday as well, what is needed to be done to get the answer as to how we best manage these patients? Because it's a recurring theme, and it may be that we need the enormous randomized controlled trial, but that's many years in the future. What else do you think is needed in terms to kind of crystallize how we manage this?
Yeah, education is a big part of it. I think we can have all the goal-directed fluid protocols we want, but I will say that in some instances it's quite disappointing how slow physicians are to be adopters of evidence-based medicine. That term has been around for probably 20 years since I was a medical student, And I can tell you, in my own travels, my own institution, it's fairly difficult to get practitioners to adopt evidence-based medicine. They pick and choose what they like and what fits their narrative. So I think as departments, sometimes there may have to be standardization that comes down from higher levels of governance and says this is how we're going to do things. So we standardize the practice and reduce that signal-to-noise ratio.
So do you think, in a way, we as physicians need to kind of step off the high horse a bit and think that our way is the best way?
Yeah. Every physician thinks he's the smartest guy in the room, and all his patients do the best and has the best outcomes, and he knows exactly how to do this because he's been doing it for 25 or 30 years, even when the data doesn't support that. So we all have to learn how to work as a team a little bit better and learn how to implement best practice into our current practice.
Can I ask what in your institution, what is the setup with goal-directed fluid therapy, intraoperative targets?
Well, we started with our orthopedic hip cases. We had a very long duration of stay for our hip replacement surgery, a lot of wound infections. Hospital got together, they developed a joint replacement team that involved physical therapists, nutritionists, anesthesiologists, pain specialists, etc. And we really focused on goal-directed fluid therapy in that group with a protocol using volume responsiveness, very, very strict parameters, and as a team approach with good preoperative care, stopping smoking, pre-op hydration, better infection control, better ambulation, we reduced intraoperative or postoperative length of stay from about 4 or 5, 6 days down to about 2.5.
Wow.
So that's a big collected effort. It was a lot of heavy lifting by many groups, but I certainly think that fluid management, changing blood transfusion, etc., the whole gamut was part of that success.
But in your fluid regime, did it err to the side of your beliefs that you kind of started the vasoactive substances sooner rather than later? Or?
I do, because if you recall the LELO data from British Journal of Anesthesiology, where they showed essentially a 7-fold difference in fluid administration based on the stingiest provider to the most generous provider in GI surgery, I went back and looked at about 2 years of our hip data and found almost identical findings. We had about a 5.5-fold difference in fluid administration when normalized to patient's body mass, duration of surgery, urine output, and blood loss.
It's unbelievable.
So when everything was normalized, taking out all the patient-centered factors, we still had a 5-fold difference in fluid administration. So you have to step back and say, what is the anesthesiologist giving fluid for? Many times they're chasing urine output that's low, even though the patient's already hypervolemic and perhaps has just, high ADH secretion. So there's a lot of places we can intervene to start to reduce that variability and get us into best practice.
And along the same lines, I'm wondering if you could talk to me a bit more about the Glycocalyx. I know this is an area of interest for you, and an area that I think from the bench top of the science books, sure, but I rarely ever think about the Glycocalyx during my everyday clinical practice. Mm-hmm. Is that wrong? I think it is probably wrong, but what should I be doing? What should we be doing?
Yeah, well, I've studied the Glycocalyx for 20 years, and I can tell you we know so little about it. Never has so much been written about so little. There are more review articles on the Glycocalyx than there is basic science data. Wow. So as much as it is the foundation of my career and my own research, I think we are not even close to a point to talk about what its relevance is in clinical medicine. I think it's an important part of the permeability barrier. The proteoglycans that make up the Glycocalyx bind serum proteins, and that gel-like layer on the endothelial surface is an important part of the permeability barrier. We know that it's degraded rapidly during inflammation, but some of the models, animal models, are awfully extreme. The LPS models, maybe not as clinically relevant as they can. I think there's a lot of problems with even the sort of biomarker data that's all in vogue right now. There's probably dozens of papers come out every month measuring some component of the Glycocalyx in the plasma. We don't know the source of them. We don't really know what they mean. It's clearly in the basic science lab. It's an important part of the microvascular barrier, but I think we're far away from being able to intervene at the clinical level.
Do you think there's more damage to the Glycocalyx than we appreciate in the routine major surgical patient, or, again, too difficult, too hard to say?
I don't think we know. I think there's been a series of new papers that have come out that have shown very little shedding of the Glycocalyx. So we're sort of working at two extremes. There was a lot of early papers that showed significant increase in circulating markers, but we don't know where they're coming from. I mean, to simply draw plasma and do an ELISA and say, oh, there's increased syndican or heparin sulfates in the plasma, without knowing where it came from, without the clearance rates, there's a lot of technical difficulties in interpreting those.
And the focus of all this is to try and work out, correct me if I'm wrong, that we give lots of fluid, and it's very easy for us to make patients edematous due to kind of the integrity of the vascular membrane, for want of a better word. But it takes a long time for that then to resolve, and that has impacts on patient outcome.
Yeah, absolutely. I think there's a lot of things that we do that make the microvascular barrier leaky. Inflammation is one of them, and we can intervene on that perhaps with things like lidocaine infusions and anti-inflammatory drugs. Giving crystalloid washes down the colloid oncotic pressure that just through simple Starling forces will increase fluid transport across the vascular wall. And I don't dispute that the damage to the Glycocalyx will add to that leakiness. I'm just not sure that we understand it as well as we think we do.
What do you, for a broad question, what if you could change one element of the enhanced recovery or goal-directed fluid therapy in your institution, what would it be? Are there still some battles not yet won from your perspective?
Yeah, it's very, very difficult to get anesthesiologists to curb their fluid. I think if we really wanted to have a premier program, all fluids would be on an IV pump. We're a very large robotic surgery center in Chicago, so most of our cases are done through minimally invasive surgical means, either robotically or laparoscopically. Our patients are drinking Gatorade overnight. They come in, they're well hydrated, they're getting an IV in the morning of surgery. They're coming into the operating theater, they're losing 50 cc's of blood in a 2 or 3 hour surgery. They don't need 2 or 3 liters of fluid. I mean, so and I think what happens very easily is they get a second IV put in. That IV is left open. They get a little bit more fluid than they should. So I think it's really difficult to curb that randomness that goes along with fluid administration. I think one way, in an ideal world, all fluids should be on a pump.
And do you think we should adjust more to the impact of laparoscopic surgery on the cardiovascular system, that more often than not, people don't adjust their regime, their goals in light of that? Is that something that needs to be addressed as well?
I think so, because we're doing big surgeries robotically, losing 50 to 100 cc's of fluid. Combined with urine output, patient may only need 500 cc's to be euvolemic. And after that, it's just going to be the appropriate use of inotropes to balance off the vasodilatory effects of anesthetics.
Dr. Randall, it's been a pleasure talking to you. Thanks very much. We're out of time now for podcast number 9, but hopefully talk to you again later in the meeting. You can join us a bit later on the conference and catch all the podcasts on www.topmedtalk.co.uk. That's it from me for now, and I'll see you later.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.